Okay, so we're going to talk about Chapter 13. This is nursing care during newborn transition. Newborn transition just means when the baby is transitioning from intrautero to the outside world and how they're going to change and function to do that. Okay, so newborns, once they're first born, have to really rapidly kind of change from having circulation inside mom to being able to breathe on their own. So respiratory adaptation is going to be our biggest thing that we have to watch for these babies. So they're going to have to fill their lungs. They're going to have to absorb that fluid that's inside the lungs because they already have fluid in the lungs when they're born. So that fluid's got to get reabsorbed, and they've got to start exchanging oxygen and carbon dioxide on their own. So this is a major thing that has to happen inside these babies. So during vaginal delivery, most of that is squeezed outside of those lungs. However, if they have a cesarean section, sometimes that fluid doesn't get squeezed out. Therefore, they have a little bit more, a little bit harder time during transition from a C-section than they do with the vaginal delivery. So chemical changes stimulate that respiratory center in the brain to start changing as when that baby's born. Most of that strong respiratory effort is going to occur during that first few minutes of life. Babies have to have surfactant. That surfactant is what's going to allow the movement of the lungs and have that nice movement. If babies are premature, sometimes they don't have enough surfactant. Even if they're mature, sometimes your babies with diabetics or hypertension, that surfactant could be an issue. So it's something that we have to always be aware of when a baby is born, and if they start having any grunting, any difficulty breathing, nasal flaring, anything like that, we're going to want to watch for that. But surfactant has to be there in order for those alveoli to work properly. Okay. Sorry. Okay, so things that we would want to look for. One of the very first things we're going to look for, sometimes when the babies are first born, they look fine. Everything looks like it's going okay. And then about the first 5 minutes after, you start noticing and it's quick. So, you think, oh, baby's born, 5 minutes, you might start seeing tachypnea. And this may be immediately, or sometimes you may see this 4 to 6 hours after birth when they're trying to transition and they're really having difficulty transitioning. So you'll see tachypnea. So those respiratory rates are going to go up. You're going to see nasal flaring, grunting, intercostal or xiphoid retractions where they're going to retract and come out and retract and come out. Unequal movements of the chest and abdomen. So you can see that effort that they're really trying to do. And you might see central cyanosis. There's a difference between peripheral and central in a baby. Peripheral cyanosis is called acrocyanosis and is very, very common for the first 12 hours after birth. So it's not uncommon for babies to have their hands might be a little bit blue and their feet might be a little bit blue. And that is perfectly normal for them. However, if it's central, that means you're going to see it in the trunk. You're going to see it maybe in the circumoral, in the mouth, something like that, the mucous membranes. Central will be their abdomen. If you start seeing it there, then we know we've probably got some type of respiratory problem going on, and we would need to recognize that very quickly and figure out the cause, and then treat the cause. Okay, so cardiovascular adaptation, we've already talked about the 3 shunts that we have. So all of those shunts have to close. So that foramen ovale valve has to close, the one that's between the 2 atria on the top. The ductus arteriosus has to close. That's the one that's attached from the pulmonary artery to the aorta. And then the ductus venosus has to close. So that's the one that's shunting from the liver. And these have to occur really, really quickly. As soon as that baby takes that first breath, things are starting to shut down, things are starting to close, circulation's starting to change, all of that is starting to change. So it changes because of the pressure. Think of the pressure inside the moms and negative pressure. Once they come out, they have the positive pressure and it's changing all in that, and that is what's causing that to adapt. And that circulation has to occur in order for that baby to function normally outside of the mom's space. Thermoregulatory adaptation is the next big thing. So they got to get respiratory, they got to get cardiovascular, and then we got to keep them warm. So the body has to adapt with that. And a lot of times babies are going to have difficult with this. They have prolonged heat loss, especially if we're not getting them warmed really good. They don't have the clothing on that they need. If their body is wet, if their hair is wet, anything like that. So they're very, very prone to heat loss, and they really don't know how to make heat yet. They cannot shiver. They don't know how to make heat. So they have a very large surface area in relationship to body mass. So that surface area is large and their body mass is not, so they're going to lose heat very quickly. They get into something called cold stress. So cold stress is something where when the babies get cold, they're not able to shiver, so they start breaking down what we call brown fat. Brown fat is their subcutaneous tissue, and so they use that to heat their body, but they don't have much brown fat. A term baby is going to have way more brown fat than a premature baby is, but we don't want them to use up their brown fat because that is what they use for insulation, that is what they use for heat. So we don't want them to use that brown fat up, and so that's how they kind of lose that. So just be aware of cold stress is something that we don't really want to happen, so we want to make sure we're drying them thoroughly, make sure that they have dry clothes on, put something over their head, to keep that heat loss in. So all those are things that we want to do immediately after birth. So ways that the babies can lose heat. We've talked about this in lots of different ways, but conduction. So one of the ways is if we place a baby on a cold surface. Think about placing a baby on a scale. That scale is a very cold surface, and that's going to conduct that cold heat off that scale into my baby. So it's going to conduct it. So it's going to take it away. Convection is like if we have air currents blowing over the newborn. So think about air conditioner vents placed by a drafty window, placed on the outside wall of something where there's more of a draft. Evaporation, this will be where if we do not dry our babies good. Like if we leave them kind of cold or wet, and that's going to evaporate and it's going to take that heat with it. And then radiation is where you put a cold object close but not touching your newborn. So you might have like a cold area, and it's going to kind of convert over to that newborn. So just know those 4 ways that babies can lose that heat. And that's real important because our babies, again, can't shiver, so they can't make heat. So they're going to use up their brown fat, and it's going to cause what we call cold stress. So be cautious of that with your newborns. So temperature taking in a newborn is going to be really important. Sometimes we will actually go in. They do vitals once the babies are stabilized. We do vitals every 4 hours. But if you've got a baby that's kind of been struggling with their temperature, there is nothing wrong with going in and taking their temperature every hour, every couple of hours, just to make sure that we're catching that. Because the more that the baby's in cold stress, the more that they can also develop hypoglycemia. So we want to start looking, just making sure that we're doing okay. So that baby needs a steady supply of blood glucose. So usually a baby's blood glucose is we're going to say that it is abnormal below 50. And I know in an adult we'd be like, oh my gosh, 50, that's low. But in a baby, any glucose below 50 is going to be considered hypoglycemia. And we're going to see that. Babies that are born to moms that have hypertension, diabetes, whether it's gestational or whether it's, insulin-dependent moms. If the mom's been in labor for a really long time, that baby has been using up a lot of their energy stores. So they're going to need extra sugar. A baby that's been in fetal distress during labor. Maybe a baby that got caught in the birth canal for a while. Maybe they had shoulder dystocia. Maybe the mom was pushing for 3 hours. If moms were given tributylene, sometimes that will cause them to have hypoglycemia. So we want to look for all of those kinds of things. So other characteristics that we're going to look for hypoglycemia in a baby is if the baby's born that has intrauterine growth restriction. So let's say we had a baby that the doctors decided to go ahead and induce labor because baby was had intrauterine growth restriction. So something was going on causing that baby not to grow like it should. Macrosomia, those are our diabetic moms. The babies are large. So we might have a large for gestational age or a small for gestational age. If the baby's premature, post-mature, respiratory or cardiac depression during resuscitation, infection, any of those things is going to increase that metabolic demand on those babies. And when that metabolic demand is increased, Just like you, if your metabolic demand is increased, we need extra sugar. Same thing with our babies. If they have been stressed, they need extra sugar also. So that's going to be important to know. So what are we going to look for our babies? Early signs, start looking for the early signs. The early signs are going to be poor feeding. They're not wanting to eat good, and they're just like sucking, and they're just really listless. We can't get them to wake up. They're really tired. And when they do, they're kind of shaky and jittery. Those three things are something you're going to want to look at. So their temperatures are going to be very unstable, and they're going to be low. So the biggest three things that you're going to see: low temperature, difficulty feeding, listlessness, and they're going to have a little bit of jitteriness. So those are the big ones that you're going to want to look at. You might see a higher weak pitch cry, but you might not recognize that. You will recognize that triad of those three things: poor feeding, listlessness, and low temperature. Those are the things that we're going to look for. So if we don't catch it and they go into late hypoglycemia, this is where we're going to start seeing the respiratory distress, apnea, seizures, and a coma. So we really want to catch it here before it gets to that point. We're really having some difficulty with that. All right, so liver adaptation. So you think, okay, well, the liver's got to do something too. So during fetal development, the babies are going to have a lot more red blood cells circulating around because they want to make use of all that available oxygen before birth. So before birth, they're not breathing in oxygen. So what oxygen they're getting is coming from mom. So a lot of times we have a really high hematocrit in a baby because they need to have extra red blood cells to get to all of the tissues because they don't have the respiratory system yet. So after birth, when the lungs start functioning, the liver is going to start breaking down all of those extra red blood cells that we have. So if we have extra red blood cells, it's going to give off that bilirubin. So when a baby's born, we have something called conjugated red blood cells, and we have unconjugated red blood cells. Conjugated blood cells means that they are hooked onto, it makes them water soluble, so the body can just absorb those. But if they're unconjugated bilirubin, it means that they're fat soluble, and the babies can't get rid of that. So we end up with what we call hyperbilirubinemia. So bilirubin is a byproduct of the breakdown of those red blood cells. So the babies can't really, that unconjugated, they can't break down. So the conjugated, we want the conjugated. We don't want the unconjugated because the unconjugated is fat soluble and we can't really break that down. So that byproduct of that red blood cell is bilirubin. So we get extra bilirubin floating around, extra bilirubin, that unconjugated. So it's kind of more fat soluble. So they can't handle that excess. So then that baby's going to get a little bit of jaundice, or they're going to get a little bit of yellowness to their skin. Physiological jaundice is kind of normal. So it's normal for every baby to get a little bit jaundice just because of the hepatic adaptation. So it occurs after that first 24 hours. And the levels are usually going to peak about day 3 to 5. And bilirubin levels don't usually rise rapidly. So a 24-hour bilirubin, every baby that is discharged, moms have to stay for 24 hours because the babies have to have a pre and postductal, the babies have to have a bilirubin level, and they have to have a hearing test. So 24 hours old, every baby's going to get a bilirubin. At 24 hours old, a baby's going to get a pre and postductal, which we talked about that before. But they have to get those. We want their level to be less than 6. If it's greater than 6, that baby may end up having to stay because of the extra bilirubin that is being broke down. So always remember your bilirubin needs to be less than 6 in your babies. And usually it should be 0, but we're okay with 6 or less in our babies. And that would be a normal thing for them to happen because that liver is still adapting to learning how to break down those red blood cells and learning how to process them and get rid of them. Okay, so pathological jaundice. So we got physiological jaundice. That is kind of a normal occurrence, and that's why the babies have to stay for 24 hours. Now we get into pathological jaundice. Pathological jaundice just means that it is becoming a problem. It's a disease now. We've got to treat it. So it's going to occur in that first 24 hours. All jaundice needs to be noted and needs to be recorded. It needs to be documented in that baby's chart. The other thing that happens is the liver at birth really doesn't know how to produce clotting factors, because vitamin K is usually produced in the GI tract, and it's produced by the E. coli in the GI tract. Well, the babies have never been exposed to any bacteria yet, so they can't manufacture vitamin K. So if they can't manufacture vitamin K, they're not going to have any clotting factors. So immediately when a baby's born, we're going to give them vitamin K, and it's usually an IM injection that we're going to give in their leg, and that's going to help prevent any hemorrhaging or anything in those babies. So usually they have to have their vitamin K before they get circumcised. That way we don't have a potential for them to bleed. If the parents choose not to get a vitamin K, which we have had parents do that, the babies cannot get their circumcision until, I think they usually do it about 2 weeks after, until the baby's had a chance to start developing clotting factors on their own. So behavior and social adaptation. So when we think about behavior and social adaptation, each newborn's going to have a different temperament, different personality, and they're going to kind of be pretty quick. They're either going to be, pretty happy babies, pretty docile, or they're going to be, kind of cry babies. So we're going to look at all of those kind of things, and we're going to do a neonatal behavioral assessment scale. And that's kind of based on that newborn's personality. It's going to be very individualized, and it's how that baby's going to communicate. So each baby's going to have 6 sleep-wake cycles. It's going, how like we have sleep-wake cycles. We go into like so many REM 1 and 2, and then 3 and 4, and then we go into REM. These babies are going to have what they call like a deep sleep, a light sleep, kind of drowsy, quiet alert, and active alert, and crying. So those are the ones that we're going to kind of document as far as like how their sleep cycles are. It's kind of hard in the beginning because you're still trying to get to know that newborn, but within 24 hours or so, you kind of start to get to where you know their temperament. And as moms go home with these babies, they kind of understand what their temperament's going to be. And each one of these babies are going to have a very uniqueness about how they're going to sleep, how many hours, and what of these 6 cycles that they're going to be in. Okay, so the assessment of a newborn at birth, it's the nurse's responsibility to assess these babies. Yes, the doctor's going to come in and look at them too, but the nurses are going to be the first one that's going to see them. The pediatrician might not see them till the next morning, because they won't even know they're born yet. So it's our responsibility to make sure that we assess that newborn and look for anything that is abnormal. So cardiopulmonary adaptation, we want their cry to be very strong and healthy and like a real lusty cry. We want that heart rate to be over 100. Any babies that heart rate is less than 60, we will start CPR on. So we want that heart rate to be greater than 100. The more that we can get that baby to cry, the increase that heart rate, the increase the pressure in the lungs, and the more things are going to start adapting more quickly. Every baby is going to get an APGAR at 1 minute and 5 minutes. Those APGAR scores kind of tell us how well that baby's doing. And so we look at 5 different things. We're going to look at heart rate, respiratory effort, muscle tone, reflex irritability, and skin color. So they're going to get a 0 to 2 for each of those things. So the highest they can get is a 10, and the lowest they can get is a 0. So looking at the APGAR score here, this is how you're going to do an APGAR score. So you're going to look at their appearance. Blue, pale, blue, no cyanosis. And pulse rate, less than 60, 60 to 100, greater than 100. Grimacing, this is like no response. So it's kind of like they're crying. What are they doing when they're born? Are they lethargic? What are they doing? Are they flexing? Are they doing what they're supposed to be doing? So we're going to be looking at all that. And respiratory effort. If they have a strong cry the minute they come out, they're going to get a 2. So I've seen babies with 0s. So we've coded them at 1 minute, and then sometimes at 5 minutes I've seen them at a 6. So it kind of just depends. Those babies we're going to watch a lot closer for that hypoglycemia because they've had some stress. So we're going to monitor those babies a little bit closer. So we're going to still be watching our babies during that transition, which is like the first hour to 2. After that, usually the first 4 hours after delivery is going to be real critical in watching and observing for anything going on in the respiratory, cardiovascular problems. If there's a lot of mucus, any cold stress, so we're going to be watching that temperature, and we're going to be watching for hypoglycemia. So those are all the really important things that we're going to look for as far as that first 4 hours after life. So the admitting examination that we're going to look for, the admitting exam has to be done within 2 hours after birth. So one of the nurses is going to look this baby over within 2 hours after it's been born. So we're going to look at the mom's history and see if there's any history of cleft lip, cleft palate, spina bifida, hypertension, diabetes, anything like that. So we're going to look at mom's stuff first. We're going to conduct make sure we're doing it in a warm area. So you want to make sure we're not losing heat loss because you're going to undo this baby. So a lot of times we'll do it on the radiant warmer so we can keep that baby warm. So make sure that there's plenty of light. We don't want any drafts coming through, any air vents blowing, anything like that. We're going to usually do it in a general order. So you're going to start at the top, work your way down. So this is, we're going to look at specific measurements. So we're going to do all that kind of stuff. So we're going to look at respiratory rate, heart rate. Usually when we look at the respiratory rate and heart rate, we want to do it while the baby's sleeping. It's the easiest way to do it, and it's probably the most accurate way to do it. So a lot of times when we go in to do a heart rate or a respiratory rate, we're going to have the baby sleeping, and we just put our hand on the baby and get a respiratory rate, and then you kind of sneak your stethoscope in there and just listen to their chest. Because once they're awake, it's really difficult to get those. So try to do that while they're awake. Like I said, we're going to do it from head to toe manner. We're going to inspect each body part. We're going to look at everything to make sure everything looks like it is in functioning order. And look at all that good stuff. So we're going to look at symmetry. Symmetry would be, are the ears and eyes symmetrical? Is the face symmetrical? Nares symmetrical? Clavicle symmetrical. So we're going to look at all of that. Does the baby look well nourished? Is there any cyanosis? Is the head larger than the body? Is the neck short, like where you would think about like a chromosomal abnormality? Does the chin rest on the chest? Do they maintain flexion? Are they clenching their fists? Looking for all of these kind of abnormalities that you might want to look for. So we're going to do vital signs. You need to know the vital signs. Respiratory rate in an infant, anywhere from 30 to 60 is fine. So when they get over 60, we start with that tachypnea. Anything over 60, we're gonna start looking for some of the nasal grunting, any kind of abdominal pushing, any type of retractions, anything like that. Sometimes that's just because they're cold. So take their temperature, warm them up, and sometimes that respiratory rate will come down. Sometimes it's because of hypothermia or hypoglycemia, so we want to look for that. So their heart rate, 110 to 160 is best, but it depends on their activity. Sometimes, if you get a baby and they're just screaming and mad, you might get a 180. But once that baby settles down and they're happy, it may go down to 150, and then it's normal. So we're going to look for that. We're always going to take an axillary temperature. The only time we would do rectally is if we're getting very low temperatures and we need an accurate temperature. Then we might go do a rectal temperature, but it would only be looking for an emergency situation. It would not be routinely. We're going to take an axillary routinely. We want that to be between 97.7 and 99.5. So between there, we're considering that baby okay. Blood pressure, systolic between 60 and 80, and diastolic between 40 and 45. So we rarely do a blood pressure on a baby unless we suspect something's wrong. Your babies in the NICU will get them, but your babies in general population or general nursing, we're really not going to do blood pressures unless we suspect something, and then they're probably going to be transferred to special care anyway. But with blood pressures, we just have to make sure we have the correct cuff and size of cuff that you're going to be using. So as far as physical measurements, we're going to physically measure that baby. So we're going to look at weights. Anywhere from 5'8" to 8'13" is kind of going to be considered our normal weights. Anything over like 8'13", we're going to be consider that kind of like large for gestational age. So we're going to be looking back at that mom's history. Any baby that's less than 5.8, we're going to be looking at, maybe that baby had intrauterine growth restrictions, small for gestational weight. So one thing that is very, very common is for babies to lose weight. They can typically lose 5 to 10 pounds in those first few days. They should gain that weight back usually within that 7 to 10 days. Most of the time, the reason those babies lose that much weight is because of a shift change in the weight. So usually it's they don't have enough fluid or liquids. So usually it is from dehydration, and they're not getting those fluids and liquids like they were used to getting inside mom. So usually that's more of a fluid shift, more liquid problem, more dehydration. Once the baby starts eating and drinking, it's going to gain that weight right back up. Usually your babies are 19 to 21 inches. Frontal occipital circumference, that's usually, and that is frontal to occipital. So it's right above the brow to the back of the occipital. And that's important because we want to make sure that the babies don't have any kind of hydrocephaly or anything like that. So if you get somebody that has a 16-inch frontal occipital, we would want to report that to the doctor because there may be something going on inside there that we need to be aware of. Chest circumference should be 12 to 13 inches, so we're going to look at chest circumference here over their chest, and all these are really important measurements to make sure that we're looking at the normal ranges of what the babies need to be. Skin should be good and supple. They should have good skin turgor. It might be kind of reddish at birth. It depends. If they're post-date, they're going to be kind of dry and cracked. If they're on time, they should be kind of reddish at birth, and their skin should look pretty good. They should have, if they're early, the earlier that they are, the more vernix they're going to have. The later that they are, the less vernix they're going to have. Vernix is just kind of like a natural lubricant that gets on their skin, and we see it more in the skin folds, and a lot of times you can just rub it in, and it's kind of like the best lotion that you could probably ever get is that normal vernix that's on the babies. Lanugo is hair, and it's kind of like a fine coating of hair. Sometimes you will see that on a term baby on their backs, and it's just like a fine little coating of hair. You might see it on their shoulders. The more lanugo they have, the earlier that they are. So if they have a lot of lanugo, your babies that are born at 26, 28 weeks will have lots of lanugo and lots of vernix because they're early. The further they get on in gestation, the less of that they're going to have. Melia just looks like little clogged ducts, looks like little white pimples. We tell parents those will go away. There's nothing to worry about, and they will go away on their own. Acrocyanosis is where they have bluish of the hands and feet. That is normal. Modeling's kind of like bluishness up the legs. Those are all kinds of normal too. Jaundice at birth, we talked about that. That's kind of normal. Birth trauma, we're going to look for that. Do they have any bruising to the face, any indentations here, any asymmetrical of their face from maybe the fifth cranial nerve they had to use the forceps or anything like that. Scalp and hair should be soft and kind of silky looking. They should have fingernails, and they should extend to the end of their fingertips, and we'll be looking for all that to see where that's at. Head and face, the head's naturally going to mold as it comes through there, but two things we want to look at would be caput succedaneum and cephalohematoma. We're going to look at those cranial sutures, and we're going to look at the fontanelles. So the biggest thing about a cephalohematoma is it will not cross the suture line. So when you look at this baby, you can kind of see the suture right here. This is underneath the periosteum. So the periosteum's right here. This collection of blood is underneath that. So it will never cross that suture line. Where caput succedaneum is just blood filled under the skin, but it is not under the periosteum. It's not under the perineum. The periosteum here. So the periosteum is still intact, and then you get the collection of blood over the top. So these are different. This one is just a collection of blood over the top, and it's on top of the periosteum. This one is underneath the periosteum, and it will not cross that suture line. Now your sutures, I'll talk to you about those on the next slide. But face, you want to look at that symmetry. Is it symmetrical? Did they have any birth trauma, anything like that from those forceps? maybe just coming through the birth canal. Sometimes those forceps can damage that fifth cranial nerve and they can get facial paralysis. So we're going to look for that. But here's your sutures. So here is your anterior fontanelle. Here's your posterior fontanelle. Here is what we call sutures. And these sutures will override. They will come over the top of each other if they have to in order for them to get through that birth canal to come down. So sometimes you will have overriding sutures, and you may see that on some of the charting when we get to do charting. So your initial head to toe, eyes, they may be blue, gray, kind of dark. They might be swollen. They might have real swollen eyelids. They should be clear. The pupils should be equal and reactive to light. They should have a red reflex, and we can test that with the light looking in there. They will have very uncoordinated eye movements, so their eyes might go all kinds of different directions, and that's normal. They might have strabismus, where both eyes kind of go in, and that's normal. Doll's eyes, where you put their head down and go up, and the eyes go up like a doll's eye. That's normal. We look for all those kinds of things. And, we look. They can see, babies at birth can see about 8 to 15 inches from their face. So about 8 to 15 inches is what they can see. They will not have tears yet when they cry, so don't be looking for tears because there won't be any tears. They shouldn't really have drainage. If they do, it might be clear. The nose might be flat. They might not have really a bridge yet. That will come. They should have, their nose should be patent, so both nares should be patent. There should be no nasal flaring. And they will have a sense of smell already. They can smell their moms when they come out and know what they smell like. Mouth, mucous membrane should be moist and pink. They should have the uvula, I always call it the hangy down thing, that's called the uvula. It should be midline. They should have a suck and a gag reflex. Their palate should be intact. So a lot of times we'll run our finger in there and check that upper palate and make sure that it's intact. They should be able to suck. They should have well-developed kind of like fat pads on their cheeks. Epstein pearls on the hard palate. It looks like they say Epstein pearls is kind of like what some people say look like little teeth, but they're just little hard places that are white on their palate. Those will go away. There's not anything to worry about that. Sometimes we will look for thrush. We usually can see thrush. Usually once the babies go home, they may come in, they're like, oh, they got white stuff on their tongue. It's just because they don't have any bacteria in their mouth, and anything that gets in there can cause the white patches on that mucosa. So sometimes we have to treat thrush, and we just use a certain medication for that. Ears. The pinna, this is the pinna, is very flexible. So when you push it down, it will recoil back really good. Sometimes babies that are premature, you push it down and it stays there. They don't have really good recoil. So we'll look to that. We want to look for where we want to look for where the ears are set. So you want to look, the tips of the ears should be right at the eye. If they're low set, sometimes that can tell us that there can be like a chromosomal abnormality, so we're going to look at something like that. We do a hearing test on all babies. When they're born, they have to have a hearing test before they leave. Sometimes they will fail it. Sometimes they'll fail it in one ear. We don't really worry too much about the first failure. We'll try to do it again before they leave. Sometimes they can still have amniotic fluid in their ears, and that can prevent the conduction. Sometimes they can have just like cerumen in there that's been collected while they've been in the womb, and that can cause that too. If we get a baby that doesn't pass it twice, they will have to come back and have it repeated. The third time that they fail, we usually do refer them to a audiologist to make sure that it's not a sensory neuro hearing loss. Because sensory neuro is something that will not get better. If it is obstructive, then removing everything out of the ear will help. But if it's sensory neuro, that's a neurological problem, and it's going to require more intense evaluation. Neck, it should be kind of short and thick. They should have full range of motion of their necks. There shouldn't be any masses, anything like that. They should be able to hold their head when on their belly. So if you put this baby on their belly, they should be able to hold their head up. Maybe not long, but they should be able to hold their head up. Like this baby, when you pull them up by their arms, their head might lag, but then they should be able to start trying to pull their head up. Their clavicles should be intact, so you will feel for any broken clavicles as they've came through that birth canal. Chest, it should be kind of barreled chest. They should have a good xiphoid process. That chest movement should be equal and bilateral. Breasts might be a little bit enlarged. They could even be a little bit engorged. And that's not uncommon. So the breast kind of might, and parents might even ask you, well, their breasts kind of look big. And that's normal. That's from changes of the hormones and all the hormones that are happening. That can be in boys or girls. Supernumerary nipples just means sometimes your baby can be born with more than one nipple. They might have a third nipple someplace. And that's normal. A lot of times we will look, it's not normal, but we will look for that and make sure that it's documented, and that may be something that they may want to watch. But that is something that can happen. Abdomen should be dome kind of shaped. They should have diaphragmatic respirations. It should be soft, no masses. Umbilical cord should be well formed. They should have 3 vessels: AVA, artery, vein, artery. Vein is what is carrying your oxygenated and nutrients and everything to the baby. The 2 arteries is what's carrying it back into circulation, back to mom. There shouldn't be any redness or drainage or anything at the base of the umbilical cord. The clamp should be on securely, and they should have some type of security device on. Genital urinary, they need to void within the first 24 hours. If they have not voided within the first 24 hours, we need to be looking about why they're not voiding. It will be light in color, probably won't have any odor. Little boys, as soon as you get them warm or you open that diaper, they'll start to squirt. Little girls will do the same thing, especially if you're giving them a bath and you take the diaper off and they feel that breeze come through there. A lot of times that will stimulate them to pee. Males and females may have that swollen genitalia. They might even have like smegma. Smegma is like the white stuff inside when you pull the foreskin back. That's all normal things that you might see. Now, ambiguous genitalia just means that sometimes during development, maybe the penis didn't develop or the clitoris didn't develop, so it's hard to say if they're male or female. So that would be when the doctor would come in and they would look inside the abdomen for ovaries or testes, to determine what the sex of the baby was intended to be. And so we call that ambiguous genitalia. Female, the labia and the clitoris might be very edematous. They might have a hymenal tag. Pseudomenstruation just means sometimes parents get really upset if they're little girls. They'll get them home. Usually doesn't happen that first 24 hours that we have them. They'll go home and they'll have a little bit of bleeding from like that vaginal canal. And that's called pseudomenstruation, and it's normal, but it does scare our moms. So it's something that we need to let little girl moms know that they might have a little bit of bleeding from there, and that's normal. Males, look at the position of the urinary meatus, which means where is the position where the urine is coming out. Sometimes we can have something called epispadias, hypospadias, or pymphosis. So epispadias just means that the urethra opening is on the top of the penis. Hypospadias is on the bottom. Pymphosis means that the foreskin is too tight and it's cutting off circulation to the glans penis up there. So we want to make sure that we are looking for all of those things, because sometimes little boys might have to have surgery for those things, so we would want to look for that. We're going to make sure that the testes have descended into the scrotum, so we're going to feel and check, make sure they've descended. If they haven't descended, they might have cryptorchidism, which means that they are hidden up in the inguinal canal, and we might have to bring those down. So we will look for all of those kinds of things. Extremities, we want to make sure they have good posture, good flexion, good return to flexion. So you might pull their leg down and let go and make sure that it flexes back up. So we want to make sure it does all those things. They should have full range of motion. They should have strong femoral pulses. One thing we look at is we will do a hip flexion and we'll rotate their hips and look for a hip click. Sometimes babies can be born with hip dysplasia, so we want to catch that early because we can treat it. It just needs to be caught early. So make sure they have 10 fingers, 10 toes. Make sure there's no webbing between their fingers or their toes. Sometimes we'll have something called polydactyly, which means that they have an extra finger or an extra thumb. We're going to look at simian creases on the palms. I'm trying to show you my hand. On the palms of their hand, if you look at your hand, you will have 2 creases. A simian crease just means they have 1 crease all the way across their hand. I've seen kids born with 1 simian crease on a hand and they had nothing wrong with them. However, it's very common for Down syndrome babies to have bilateral simian creases. So we'll look for brachiopulses. We look for bowed legs, club feet, all of those kinds of things. And like I was talking about the hip click, we would be looking for a hip click or anything like that that we would want to make sure that they don't have. So we're going to do what we call Ortolani and Barlow maneuvers. These are the maneuvers that we're going to look for the hip click. So the doctor brings their hips up, up and flexes them all the way up, and then he rotates them out, and he's feeling for that hip click and looking for that hip click. And if they have that, sometimes we need to investigate a little bit further. The back and the sacrum, the spine, it should be straight and should be flat. There shouldn't be any masses, there shouldn't be any openings, there shouldn't be any dimples, little tufts of hair. What sometimes we're looking for is a pilonidal cyst back there, where you look for a little dimple or a little tuft of hair, and that's where the baby, maybe the spinal cord did not fuse, and so they will get that, and there's actually a connection to the spinal cord from there. So that would be like a spina bifida that didn't happen. So we would want to look for that. Is the anus patent? Did the baby poop? If the baby didn't poop, we have to make sure they have an opening. They should poop and pee within 24 to 48 hours. A baby cannot go home unless they are pooping and peeing. And that we have to make sure that the anus is patent. If they're pooping, it is patent. We did have a baby born not long ago that hadn't pooped, and 24 hours was up, and we did an ultrasound, and the baby was full of stool. We ended up shipping that baby off to St. Louis, and they had a bowel obstruction. So these things happen, so that's why it's so important that we make sure. We just assume a lot of times babies are going to poop and pee, but if they have not, we have to make sure that we're making sure that that has happened within that 24 to 48 hour period of time. So neurologically, we're going to make sure our babies are neurologically intact. So we're going to look at their general appearance. Are they, if they're sleeping quietly, we're going to look at this. Do they maintain that flexion? So if you get a baby that is just like lethargic, their legs are lethargic, their arms are lethargic, you're going to look for that. We want them to maintain that flexion. We want that cry to be very vigorous when they cry. Abnormalities we're going to look for is a baby that has hypotone, which is just kind of like drooping. Tremors, any jitteriness, any seizure activity, any high-pitched cry, any shrill cry. Any of those things we're going to look for. It's really hard sometimes to see seizures in babies because sometimes you mistake that for just a little bit of jitteriness or something. So you really have to look for that, and sometimes it goes undetected for a while. But if they've got that shrill cry, that's one thing that we would want to look for, because that sometimes can indicate a neurological abnormality. Reflexes. So we're going to look at all these different reflexes. Sucking reflex, grasp. This is the stepping reflex. Sucking they should do. Grasping. Any baby, it's a natural reflex that if you put your finger in their hand, they're going to grasp it. Stepping, if you stand them up, they will look like they're stepping. Moreau just means that when you startle them, their hands and feet go up like that in the Moreau. This is tonic neck. So when you turn their head to one side, the other side flexes. That's what you need. We're going to look for all of those reflexes and make sure that that's happening. Most of your babies should be able to sneeze, cough, blink. If they get a painful stimuli, they should be able to pull back. Babinski is where we take the sole of the foot like this, and we take our finger and go up, and their feet should flex like that. So, well, actually their feet should flare. So if you go like this, their feet, the little toes should flare apart. So we're going to look for the Babinski. As far as behavioral, we're going to look for the interactions between parents. How are they bonding with that baby? We're going to tell them to start watching for cues. What we mean by cues is watching for the baby trying to, look for sucking. If the baby's hungry, they will start giving you cues. Crying, turning their head like they're trying to root. They'll root and try to find where the nipple is, because it's a natural reflex for these babies. So watch for those cues that tell us that baby's hungry. Maybe tell us that baby's in pain if they're crying and they're flexing a lot. So we're going to look for those. And then we're going to do a gestational age evaluation. We will talk about that in another section. So I just want you to be aware what's normal. This is all normal transition for that baby coming out of the womb. And that is it. Okay, that is chapter 13.